Hi, Kathy from ALECC. Glad that you could join us today. So we're going to continue our Is It Time series, and today our focus is going to be on pulmonary disease. This is another one of our top admitting diagnoses. We see a lot of respiratory disease, respiratory COPD, things like that, top diagnosis. These constitute some of our longer length of stays as well, generally over 100 days. And so I wanted to talk about, is it time? What are some of the eligibility criteria that we're looking for when we're admitting a pulmonary disease patient for hospice onto Medicare hospice. So a couple of the things that you need to be paying attention to. You do need to make sure that two of these do exist. We're looking for disabling dyspnea. This disabling dyspnea does take place at rest. Patients are unresponsive to bronchodilators. Generally, after a bronchodilator, their forced expiratory volume within 1 second is 30% or less. Generally, for those of us that have, normal capacity on a forced expiratory volume in 1 second, we have an 80% that we can put out with air. These patients, because they're obstructed, they're less than 30%. So we're looking for things like that. We're looking at a progression of end-stage pulmonary disease, and this is evidenced by, again, increasing visits to the ER. Maybe there's been some hospitalizations, there's been some lung infections, something going on, pneumonia, anything at all like that. You might be looking at other documentation of, generally with COPD, any pulmonary disease, you will see that they've had different lung function tests, and over the course of time, you'll see staging of these of the disease state, and you'll see a decline. So if you can get your hands on these tests that show a decline, it's not necessary, but these are nice things to have. So again, I always say it's great. It's important to get an H&P, what's been going on with the patient, why hospice, why now. Take a look at, have there been ER visits? Have there been more physician visits specifically related to this diagnosis and a decline? We're also looking at hypoxia on room air, where patients may have PO2 and O2 sats, O2 sats especially at 88% or less. They're just having very difficult time. There might be hypercapnia involved. That's evidenced by PCO2s at greater than 50 millimeters per of mercury. We are also looking at things like right heart failure. That's always associated also with pulmonary disease that could lead to cor pulmonale. So again, we're talking about, comorbidities. So if there's anything at all like that, you certainly want to pay attention. Respiratory patients also can have unintentional weight loss. Oftentimes, many of them might be taking a supplement that is pulmonary related. So pay attention to their weight and anything that might be going on with that. So if you've got a 10% or greater weight loss, you certainly want to take a look. Resting tachycardia, if we've got a heart rate that's greater than 100, these are all the things that you're paying attention to when you're looking at, is it time for admission to hospice related to pulmonary disease? When we move into non-disease specific guidelines, this is our KPS, this is our PPS, 70% or less is what we're looking at here, less than 70%, I should say. And then we're looking at a dependence on our ADLs, and we always have to meet at least 2. So as time goes on and we're looking for a decline, we're looking at feeding, ambulation, transfers, continence, bowel, bladder, bathing, dressing. So again, it's important that, you take a look at, activities of daily living. How are they functioning there? What's their cognition? Anything at all like that. Then, of course, we're moving on to our comorbidities. Again, comorbidities are one of those types of things where you just don't want to list a whole bunch of comorbidities. It's not about quantity. Again, it's about quality. How are some of these comorbidities, are they related to, or are they going to impact the primary diagnosis that we are admitting the patient for? So you might be looking at things like congestive heart failure. You might be looking at any liver disease, any other diseases that the patient may have. The patient might be a diabetic as well. They may have some neurologic disorders. There may be dementia, Parkinson's, anything at all like that. So again, this is what we are looking for when we are dealing with respiratory pulmonary disease states. So hopefully you have found this helpful. Also, when you are trying to recertify and you're looking at declines, you want to look at all of these areas. Is there a decline in function? How is their respiratory status? Has it declined? Everything at all like that. So again, please take this information, present it to your IDGs, your IDTs. This is a learning tool for you. We appreciate that you signed in. We appreciate that the work that you do, it's not easy work, but hospice is so appreciated by so many. Like and subscribe, share the video with everybody and anybody that you can. These are learning tools to assist and help you. Thank you again for the work that you do, and truly have a great day. Bye-bye now.